So we're going to go over hip with pelvis. So that's going to be 3 views. We're going to do an AP pelvis, an AP unilateral hip of the affected side, and an AP frog leg lateral of the affected side. To start out with, we're going to use a 14 by 17 crosswise to get the entire pelvis in there. You're going to put your thumb in crosswise, and then I'm going to have you put your marker, your right marker, in the bottom right corner of the cassette. That way it's going to be in the image but not in any anatomy. Again, we're going to make sure that we're in transverse D10 and we're at a 40-inch SID. We're not shielding with this image because we don't want to obscure the anatomy that we're trying to visualize. And again, I'm going to line up my tube and bucky. I would have asked my patient again, name, date of birth, pregnancy. I'd have them verify that we are doing the correct side and which body part, if there was any injuries, how long ago, what happened, and if they had any previous surgeries. Previous surgeries are really important with hip and pelvis because if the patient has had a prosthesis implanted before, we want to know that. Because with that imaging, we will need to include the entire prosthesis on the anatomy. The other thing that you can do is look at the patient's feet right away when we're doing a pelvis or hip imaging. If a patient has the possibility of a fracture, there is a telltale sign of that when we look at the patient's feet. Most of the time the patient's feet are going to be straight up or just a little out to the side. But if one foot is straight up and the other foot is turned out, and then even foreshortened just a little bit, don't look at the knee, but if you just look at the feet, this is a telltale sign of a fracture, that external rotation. So if we do see that, we don't want to have our patient roll their feet, and we would take an image as is to see what it looks like and see if there's a fracture before we start. So I'm going to start with the pelvis, so I'm going to use a 14 by 17 crosswise. What I want to do is I want to make sure that there's no rotation in my patient's pelvis. Just do a little bit. There you go. So that the as-is are equal distance to the IR. I want to find my patient's as-is. The central ray point for a pelvis is midway between the symphysis pubis and the as-is, which is a little hard to determine. So just go 2 inches inferior to the as-is. Find the as-is. I use about 3 fingers for my 2 inches, and you can measure what 2 inches is for you. I'm going to center right at that level, and then I'm going to do a double check to make sure that my patient has light, at the top of their iliac crest. So that's my double check to make sure that I'm centered properly and I'm going to have all the anatomy, is make sure that I have light at the top of the iliac crest, and my central ray is 2 inches inferior to the as-is. Then I'm going to go up to the top, and I need to make sure that I'm centered to my mid-sagittal plane so I get equal right and left sides so that I'm not clipping either of the greater trochanters. And last, if I don't see any signs of fractures, what I'm going to do is have my patient internally rotate their feet 15 to 20 degrees. And then I would just have her hold her breath and hold nice and still right there. All right. After the AP pelvis, I'm going to do the AP unilateral hip, so it is her right side that's affected. So for this one, I'm going to collimate down to a 10 by 12 lengthwise. I don't have to change my IR because it's going to fit within that. For this one, you want to center 1 inch medial to the as-is. It will tell you 1 to 2 inches. 1 inch is fine. Don't go 2 inches. And then you want to center 3 to 4 inches inferior to the as-is. So 1 inch medial and 3 to 4 inches inferior, so that puts us 1 inch inferior to the neck of the femur for our central ray point. I'm going to move my marker off of my IR here, and I'm going to put it right next to the leg in the bottom corner of my light field. I would have my patient keep their feet internally rotated 15 to 20 degrees and have them hold their breath. For the last one, for the hip, I'm going to have my patient bend their knee up and let the leg fall out to the side towards me. I'm going to straighten your leg just a little bit. My central ray point is exactly the same. 1 inch medial and 3 to 4 inches inferior. Usually tends to be right at the crease of the leg or 1 inch below it. You can turn your collimator housing so that your light is going right in line with the long axis of the femur. And I would have my patient again hold nice and still and hold their breath. And that's it for hip with pelvis.